So I have been given the brief of looking at policy into practice in Ireland. Does evidence really make any difference? And what a rich environment really to look at these quite three disparate areas: policy, practice and evidence. And it's really reassuring, I suppose, the fact that if we look at the audience, the diversity of representation insofar as we have service users, funders, policy makers, researchers and clinicians all in the one room, which is what we need going forward. So just to make sure that we're all starting at the same point, always good to begin with a definition to make sure we're all in agreement as to what we're talking about. So health policy can very simply be thought of as decisions, plans and actions that are undertaken to achieve specific health goals within a society. So in essence, it's that idea of purposive thinking bringing about actions. And the policy maker's role is really to bring forward those variety of options for then political decision making, which is where the hard choices have to be made. And policy making is often thought as the defining characteristic of the civil service. And as such, much of policy making activity actually goes on within the civil service. However, the analysis of the work in preparation for the policy can be done either by an analyst within the system or occasionally by consultants. And certainly in Ireland in the last 10 to 15 years, there's been very much a tendency to outsource a lot of the preparatory work around policy making, which can have some limitations associated with that. On the other side, when you have good, strong outsourcing, it can bring some riches and diversity to the process. But I suppose this diversity is very much reflected in our two main policy documents that guide palliative care provision in Ireland. And the first is the report of the National Advisory Committee on Palliative Care. And this policy document really was the first policy document that was solely focusing on palliative care. Prior to this, palliative care had reference in other national policy documents, like, say, for example, cancer control documents and so on. But this document was specifically focused on palliative care. And the group was actually chaired by a consultant in palliative medicine with Department of Health representation on the group. And if you looked at the group, it was very interesting because it brought advocacy groups, clinicians and policymakers into the one forum. The vision for this particular strategy document was that it would only last for 5 to 7 years. And it was really setting out the blueprint for the development of services over that period of time. But unfortunately, we haven't had an updating of this document, which is something that I'm going to come to. Within the original 2001 report, they pointed to the fact that this document was predominantly for adult service provision and pointed to the need for a children's palliative care policy document. And this indeed has come to pass, and in 2010, the Palliative Care for Children with Life-Limiting Conditions in Ireland document was produced. Interestingly, in terms of the change, this document, the committee, was actually chaired by the Department of Health, but again had clinician and advocacy representation. So the details of the 2001 report aren't probably of huge interest to people outside of our own country, only other to say that it is actually a very good document that has stood the test of time. And a lot of the reasoning for that was that you had very experienced people around the table with a good diversity of perspective who did very much draw from the evidence base of what was known at the time and used the evidence appropriately in formulating policy options. So, for example, the document itself would have over 150 references drawn very much from research base, service users' perspectives and so on. And as I say, the document was really a blueprint for development of palliative care services nationally, although the majority of the substance of the document really did focus on specialist palliative care provision. So it was very clearly laid out in the document that palliative care is an integral part of all health services provision, that is part of the duty and responsibility of all health and social care workers, that 3 levels of palliative care provision can be recognised. The level 1 or palliative care approach, which in essence all healthcare practitioners should be able to apply palliative care principles appropriately throughout the course of the care that they provide for patients and their families. And then this idea of an intermediate level of palliative care where clinicians who come perhaps in more contact with people with life-limiting conditions, say for example a cardiologist who specialises in heart failure, well these clinicians should go on and do additional education that would upskill them to be able to practice at this level. and then very clearly level 3 or specialist palliative care provision, and those were those staff whose core and sole responsibility was the provision of specialist palliative care. The document very interestingly went on to describe what exactly that specialist palliative care service would look like. It described the hospice or the specialist palliative care inpatient unit as the hub of services. It described the fact that your community palliative care services would be co-located within your hospice building, that you would have daycare services, that you would have outpatient services, that the consultants would also have sessional commitments then to the adjoining hospitals, so that the patients really would experience that integrated care journey. Very interestingly, they also provided detailed staffing levels for all of these elements of services, and they also provided costings for what that service would look like into the future. The document spoke about palliative care for non-malignant disease. It pointed to the need for further work on people for palliative care provision for children and vulnerable groups, and it also importantly spoke about the need for education training and made some reference to the importance of standards and accountability within care. So how useful or how successful was this document? Well, it did really start a period of investment with specialist palliative care within Ireland. And certainly, for example, the numbers of consultants grew from 4 up to 30. Every community, every regional area in the country has a community palliative care service, although the levels of staffing are variable. Some additional inpatient beds were opened and so on, but unfortunately due to economic considerations, a lot of the additional investments stalled in recent years. But if you look perhaps at some of the external ratings of palliative care provision, certainly Ireland isn't doing too badly on a European or worldwide scale. So turning from Ireland to the more generic question of how do policies come to be made? Well, as you can see from the list of possible theories and options as to how policies actually come into being, you can see there is a huge range of thoughts as to how this happens, and it really just points to the fact that policy making is a very complex process. Position politics, ideology and interests obviously can drive particular policy directions, but they're not the only part of the story. Very interestingly, this idea of path dependency. So for example, if you think about the analogy of computer keyboards, the QWERTY keyboard, when we were looking towards having keyboards for computers, it was always going to be dictated by actually what typewriter keyboards had been like. So that idea of historical institutionalization, so that even when governments come into being, they're interacting with a civil service that has a historical memory. And this idea of path dependency, that your choices actually become progressively more limited as you proceed down a particular pathway. Perhaps a little bit of an idealistic, but this idea of rational choice theory, that we're all actors that make rational, predictable choices. The idea that has grown very much in favour, the idea of policy networks, that policies come into being because the interactions of groups, and obviously you have people who are in positions of power, the inner circle versus the outer circle. But the two that I just want to focus on is this idea of the incremental policy change as compared to policy paradigms, which is very abrupt, dramatic changes in policy paths. And Lindblom would have originally conceptualized the idea of incremental policy change, this idea that really the social service or the civil service in many ways it never has all of the perfect amount of information to hand. They never have the perfect amount of resources to distribute. There are always hard choices to be made. So in reality, policy making is very much a process of muddling through, making the best decisions you can in the situations that are to hand. And yet, contrasting that, sometimes you do see seminal moments where there is a huge dramatic change in policy, which really can have a transformational effect on a health system. And this is the idea of policy paradigms, where you have the perfect confluence of prepared policy coming together with public interest, an event that stimulates interest in a particular area, together with government that is willing to act on that. So these two ideas that, in the main, policy making is very much evolutionary, but occasionally it can be revolutionary. So we know what policy is. We're not quite so clear how it gets to be made, but we have a few ideas. Does it really matter? Does health policy actually have an impact? And I suppose coming from a country which has really been devastated by the economic recession, there is a certain level of disillusionment and disenfranchisement with the idea of politics and policy and government. So really, is this all just people pushing paper around? Does it make any difference to the patients? And there's really been some fantastic work from the European Observatory of Health Systems and Policy that really has looked at this area, and I'd urge you to look at the publications. They've been in the Lancet, the BMJ, they've produced a book on this as well. And what they actually did was systematically look at health policy across Europe and looked at 11 areas which have been identified as contributing to major population health gains in at least some European countries. And what they actually did was they developed a number of process, immediate and distal outcome measures for all of these policy areas. And then they did case studies of each of the European countries, and they gave each of the countries a ranking in terms of how they were performing in their health policy execution. And it came up with some very interesting findings. And then they did a regression analysis to look at what are the factors that seem to impact on successful implementation of policy. Now, it would be great if I was coming to you as Ireland being the leading expert in the world on the execution of health policy, but unfortunately I come to you more as a sinner than as somebody leading the way. And our Norwegian brethren, as usual, are leading the way in this. So you can see the groupings in how people are performing on health policy. They grouped them into the indicators that were in the top third, and then the indicators that were in the bottom third of all the different health policies. And you can see Sweden, Norway and Iceland all ranking with very high functioning policies across all of the areas. Very interestingly, and a lot of learning there, that Denmark isn't forming part of that group. UK and Ireland pretty much middle of the road there. Now, does that really make much of a difference? Well, actually, if you compare our mortality rates to the benchmark of Sweden and use this index of the potential years of life lost, for many countries in Western Europe, 20% or more of potential years of life lost could be avoided if these countries had the Swedish mortality rates. And if you actually go towards Eastern Europe, it's actually up to 70%. So clearly, the execution of health policy does make a difference in terms of the health status of populations. And there's a variety of reasons why some countries are more effective than others, which isn't the substance of today's talk, but obviously things like financial means, functioning institutions, competent workforce, differences in will, which is interesting, the political will, the values of the society, how much do these issues resonate with society, the place on the survival self-expression scale, because societies tend to function more cohesively when they are more advanced on this scale, and interestingly, how well we collectively work together as a society, that we work together to achieve certain goals. So if policy is good, then surely evidence-based policy is even better. So evidence-based policy is, in essence, helping people make well-informed decisions about policies, programs and projects by putting together the best available evidence at the heart of policy development and implementation. Now, the one thing we do need to remember, being in a room, I suppose, predominantly researchers and clinicians, is that there are many possible sources of information, and research isn't the only source, although we may tend to favour it. And research can fit in, I suppose, or feed into the policy cycle at many different points. Academic theory can play a role in clarifying objectives, assumptions, rationale and mechanisms. Researchers can be of help in generating evidence from existing data, or indeed, where necessary, generating new data. Researchers can be of invaluable assistance in helping to critically appraise the results of study. And obviously, once policy has been put into practice, researchers can help evaluate how successful that has been to inform the next cycle of policy making. So tobacco control is one of the most cited examples of a successful evidence-based policy. But just as a sobering thought, we should remember that the early evidence about the dangers of tobacco use has been known since the 1960s. And yet, when you think about all of the moves within tobacco control, it really has only been in the last 10 years. So a real, I suppose, a little bit of a sobering lesson in terms of the success versus the time it can take. So evidence-based policy isn't anything new, although it has been refashioned and respun. Aristotle would have spoken of the importance of having scientific knowledge, pragmatic knowledge, and value-led knowledge in terms of informing rule-making. The US has a very strong tradition in terms of gathering population-level data and using this data to inform policy making. Evidence-based policy as a buzzword, a jargon term, very much came to the fore with the advent of New Labour, and it rose, I suppose, in ascendancy in a similar manner to that of evidence-based medicine. Australia, New Zealand and the Netherlands and Canada all similarly followed this route, but in Canada what you'll see is rather than using the term evidence-based policy making, people speak an awful lot about knowledge translation, which in essence is using research to inform policy and practice. The World Health Organization is particularly following this trend in developing countries in terms of bringing in evidence-based policy making there. And the economic crisis really for a number of countries has stimulated a lot of thought again about the role of evidence, because so many of the decisions that would seem to have been made were perhaps opinion-led rather than evidence-based. So this is I suppose the story in favour of evidence-based policy making, and we're really not going to critique it again today, but just a little bit of the flip side of the story. I think, you know, this quote from Catherine Smith unfortunately does resonate. Although we talk about evidence-based policy making, how important and valuable it is, in reality it is rare to find policies that are clearly based on scientific evidence, and extremely easy to find examples of policies that run counter to the available evidence. So there's something that we haven't cracked there, and I suppose maybe something for us to reflect on perhaps is in palliative care, where do we fit within that trajectory? And perhaps the voice is a little bit in counter to a sole focus on evidence-based policy, and maybe perhaps a little bit of a rounded or more balanced view. Who would not want health policy to be based on evidence? Evidence-based medicine and evidence-based policy have such reassuring and self-evidently desirable qualities that it may seem contrary to question their legitimacy. But then there comes in the reality. I mean, how can evidence-based policy making really survive when up against the hard-headedness of political decision making? And is it that we're all really being a little bit idealistic when we say evidence-based policy will win the day? But then as a counter to that, do we really want to return to just simply muddling through? Surely there's a better road. And I suppose perhaps we're moving to this point of a little bit more pragmatic, where we talk about evidence-informed policy making, where we aspire to the idealism of using the best evidence in terms of informing decision making, but we recognise that we live in a real world where there are other factors that can impact on the policy making process. And this quote from Francis Ruan really does speak to the fact that Ireland is a nation of storytellers and we all like good anecdotes. Statistics leave people cold. And I think this comes back to Diane's point in terms of the message, how we portray the findings that we have, because at the end of the day, if the stories that we have to tell are not as gripping as a story or anecdote, then people will not listen. So obviously the complexities of this have given rise to a lot of consideration and thinking as to what is the interface between research and policy. And the first two models of research and policy are very much linear models, where in essence knowledge, research findings provide pressure for policy development, which would be wonderful, or the problem-solving model, whereby you have a policy problem and you go and you look for your evidence in which to base your policy solution. And then we have the slightly more perhaps jaded and cynical researchers, clearly, where they came up with the idea of the political model, where research is used in a predetermined manner to support policies that have already been chosen, or the tactical model, where research is used as a delaying space to give policymakers breathing room. And then we have the idealistic people who do still see hope for the future. And very much the model that people would have heard a lot about in recent years is this idea of the two community models, where researchers and policymakers just live in different areas and speak different languages. And if we could only improve the communication between the two different camps, we would manage to overcome these hurdles. And then again, this idea of interaction, that research is just one factor among many, and the Enlightenment model, that research influences policy through indirect, diffuse processes over long periods. So a real optimist looking to the long game. So looking at those theoretical models, a number of recommendations about improving the use of evidence in policy making have arisen over the years. And this is taken from Catherine Smith's book, which I would very much recommend. And she's really grouped all of the evidence base and the systematic reviews into this tabular format. And would she say the most popular recommendations about increasing the use of research in policy and practice focus around the idea of making research accessible, developing those collaborative relationships and improving the communications between researchers and users, and then funders creating incentives for policy exchange. And I suppose this would all be very familiar to any of us writing grant applications. You make this all part of one's application as such. But if you really think about those recommendations, if you were really to look at them in the cold light of day, really what those recommendations are doing is they're recommendations to improve the use of evidence within policy making, but they say nothing about whether the evidence you're using is actually good or not good, or whether the policies are any the better for the inclusion of that evidence base. So they are some solutions, but they're only a little way along the road for us. And also, if you think back to that idea of evolutionary rather than revolutionary policy change, these recommendations really seem far more likely to facilitate instrumental, incremental kinds of influence rather than those huge changes in policy direction. So just before the final couple of slides, a recap for where we're at. I suppose I've tried to make the argument that policies can have huge impact, that basing policy decisions on the most complete evidence should lead to better outcomes, but that unfortunately policies are based on evidence to varying degrees. We do have the potential to influence policy in multiple ways, but we haven't mastered the ability to do so consistently. And these really are just the final thoughts about maybe reframing our approach to evidence and policy making in thinking about ideas rather than evidence. And Catherine Smith really has articulated this position in the book released last year. And what she would say is think about 4 types of research-informed ideas. The idea of institutional ideas, which are those ideas that are embedded within policy and society, to the point that we actually don't even really sometimes realise that they are dictating our thinking. And then you have critical ideas, which are the ideas that criticise or challenge the institutional ideas, but it's very much somebody almost outside of the fence lobbing the ideas in and criticising those. And the critical ideas actually don't present an alternative way of doing things, but they do point out the faults in the ways that we are doing things at the moment. Charismatic ideas are those ideas that provide a convincing vision of an alternative future. And I suppose Cicely Saunders really is the embodiment of a charismatic idea that literally changed the way that policy was conceptualized. And then this 4th typology of chameleonic ideas, which is a very pragmatic way of looking at this idea that ideas have elasticity and transformability and so can adapt in a variety of settings. So a little bit more of the stealth attack approach to palliative care provision. The danger with chameleonic ideas, though, is that sometimes they're not always under your control and that they can transform that little bit further. So a charismatic idea may take much longer to get into actual policy transformation. That building period may be much more challenging. There'll be an awful lot of maybe negative thoughts around the original conceptualization as the idea, but once it's there, the switch is tripped. Whereas the chameleonic ideas may be a more strategic way of going about things, but you can't absolutely guarantee that the idea will be had its original integrity. So Smith would contend that research-informed ideas then move into policy either because they already fit within the boundaries of institutional ideas, or they have chameleonic tendencies that facilitate their translation into ways. And then occasionally you can have these charismatic ideas which radically transform visions of the future. So if I were to say what then are the implications of practice? Research can contribute to policy development in a variety of ideas, and perhaps the best means of facilitating the impact of research on policy actually varies according to the extent of policy change that is being required. Researchers who are working within the boundaries of institutional ideas may find it easier to impact on policy. And researchers that are working in other areas have a number of options. One may decide to rest within the camp of critical ideas, putting forward one's thoughts, but actually perhaps not really looking forward through to the execution of those ideas into policy and leaving those to others. Or you may move beyond critical thinking and look at developing persuasive or charismatic visions of alternative futures. Or you may be more pragmatic and develop ideas with chameleonic tendencies that enable them to be presented in contrasting ways to different audiences. Very importantly, if you are working with either chameleonic or charismatic ideas, your research is more likely to have an impact on policy when there are strong links between research advocacy and policy communities. And finally then, turning back to Ireland, what does this really mean for us? Well, we're at a time of unprecedented challenge. About 22% of our health budget has been cut in the last 5 years. There's been a 10% reduction in staff. And despite this all, the health system is facing increasing numbers of patients. We're caring for greater numbers of patients with far higher levels of complexity, and also a significantly, I suppose, financially challenged population, where the numbers of patients accessing free care is at the highest in the history of the state. And very interesting, some of the work that's come from Trinity College Dublin that has really tracked the impact of this through the system has begun to pick up from the qualitative data, is that actually now there's a disconnect between senior health service manager priorities and governmental priorities. And when the ship is sinking, perhaps you just turn to trying to stabilise the ship. And actually governmental policies are perhaps, not the priorities of the frontline health service managers. Where does this leave us with palliative care? Our original policy is still relevant. We have ongoing efforts to implement it, but the pace isn't as quick perhaps as we would have liked. It's clear from our original policy strategy, our policy documents, that we need new policy development on funding models, on the development of generalist palliative care services, because the detail of that was relatively less in the original document, and improved integration with chronic disease management. So we know our wish list of what we would like to have in our next policy document, but at a time of such challenge, is it really reasonable or feasible to be thinking of getting success in these areas where there are all the other policy frames? And the policy frames for us are a public health approach to care provision, care at the lowest level of complexity, but with a focus on quality, safety and value, huge structural reform, huge financial reform. So really, I suppose where we are at within the development of palliative care services in Ireland is that we're really looking to combine fresh impetus behind existing policy, but demonstrating the effectiveness and relevance of the original policy through presentation of research findings, relevance to current problems facing healthcare, and collaboration with advocacy partners, with promotion of chameleonic ideas on funding and integration with chronic disease management and the public health approach, all of which resonate within policy frames, and engaging with international research partners in order to further our understanding of our own national performance, levering international comparisons and experience. So I think the messages that I'd like to leave you with today, very much influenced by the thinking of the authors that I've cited throughout the talk, but some of the health disparities between European countries do result from differences in health policies. And universal adoption of effective health policies throughout Europe and beyond would lead to enormous health gains. And we really should consider the importance of that and extrapolate that to palliative care, because we weren't in that list of 11 important health policies in Europe. While this would require an inspirational vision for global health and the resources to make it a reality, palliative care really has achieved a huge amount in such a short space of time. So we're extremely well placed to strengthen our links with research, advocacy and policy communities, to provide a clear articulation of charismatic ideas within persuasive policy frames and grounded on high quality research data. And really, it's the collective that will engender success in this area, and international collaboration certainly accelerates the work. Thank you.